Now in the corneal disorders, we will discuss keratopathies. Keratopathy is a broad term which is used for any kind of pathology involving the cornea. Okay, we have discussed many major types of keratopathies such as keratitis, different types of keratitis, degeneration, dystrophies, etc. But now there are also some important pathologies and disorders which should be discussed. Okay, so we will now discuss those topics in keratopathies. The first one we have in keratopathy, it is metabolic keratopathies. Okay, in metabolic keratopathy, it is the problem with the enzymes. For example, with the enzymes of lipids, with the enzymes of carbohydrates, and with the enzyme of amino acids. So when there is any problem with these enzymes which are catabolizing these products, it is called metabolic, and which when it is a metabolic pathology, when it is involving the cornea, so it will be called metabolic keratopathies. Okay, so we have many types of keratopathies, but we will discuss only the important types. Okay, we have the Wilson disease, cystinosis, Fabry disease, Mucopolysaccharidoses, and the last one is the Lecithin-Cholesterol Acyltransferase deficiency. Okay, so we will discuss each of them with their pathology, clinical features, treatment, diagnosis, and treatment. Now the first one is the Wilson disease. What is the Wilson disease? It is an autosomal recessive condition in which there is the problem with a protein called ceruloplasmin. This ceruloplasmin, it is a protein which transport the copper in the blood. Okay, so it is a copper carrier protein in the blood. So in this Wilson disease, what is happening? Due to the genetic alteration, there is the complete deficiency or absence of this protein. When this protein is not present, what will happen? The copper will accumulate in different tissues of the body, including the eye, the cornea, and lens. Okay. So how the patient will present to us with Wilson disease? The systemic features are there will be neural, as the copper is mainly accumulating in the brain, in the basal ganglia, in the liver, and in the cornea and lens. So the patient will present with these features, with the neurological problems, with the liver disorder. And when we take a look through the eye, what will happen? When we take a look through the eye, there will be a brown yellow discoloration at the peripheral cornea. Okay, there will be the brown yellow discoloration at the peripheral cornea. This is called Kaiser-Fleischer ring. Okay, this is due to the accumulation of iron on the descent membrane. Okay, so when the copper. Okay, so when the copper accumulate on the descent membrane, mostly at the periphery, it will cause this brown yellow membrane at the periphery, which is called Kaiser-Fleischer ring. So there will be Kaiser-Fleischer ring in the eye, and when we take a look through the lens, there will be cataract. Due to the copper deposition, there will be the cloudiness of lens, which is called cataract, and the cataract will be in a special pattern, which is called sunflower cataract, in sunflower pattern. Okay, so this is the lens. There will be the formation of opacities in the anterior subcapsular areas and the posterior subcapsular areas, and it will form the shape of a sunflower. So it is called sunflower cataract. Okay, so it will give us like this, a sunflower cataract in the lens. Okay, so these are the clinical features of Wilson disease. How can we diagnose the condition? As they are saying that 95% cases, there will be the ocular feature as the Kaiser-Fleischer ring and sunflower cataract plus neurological problems. So when the patient presents with these, mainly with these two clinical features, it is most probably Wilson disease. Okay. The treatment, how can we treat the condition? We will treat the condition by using copper chelating agents. We should use such drugs and medication which bind the copper and remove the excessive copper from different tissues. For example, we can use a drug which is called D-penicillamine, okay? It is a copper chelating agent. So this is the Wilson disease. Now the second one is the cystinosis. Cystinosis is also like the Wilson disease. It is an autosomal recessive disorder which is due to the problem in transmembrane protein. A protein which is present, this is the cell, okay? If this is the cell, there is a protein called cystinosine. This is the protein called cystinosine which is present across the cell, which is called transmembrane protein. The role of this protein, this cystinosine, it is mainly transporting cysteine amino acid across the cell. So when there is problem with this transporter protein, what will happen? There will be the accumulation of cysteine inside the cells, okay? So the cysteine will be excessively accumulated in different types of tissues, and it is a multi-system disease. For example, it is involving the brain, the liver, the eyes, the pancreas, the muscles, okay? So it is a multi-system disease and a rare autosomal recessive disorder. How will the patient present to us with cystinosis? The patient will present to us there are three forms, okay? There are three forms of this disease, which is nephrogenic form, non-nephrogenic form, and intermediate form. And nephrogenic form is presenting as a pediatric renal failure. So it will cause renal failure in a newborn, okay? So it is the nephrogenic form. We have the non-nephrogenic form which present to us in the form of diffuse stromal opacities, okay? So there will be the deposition of the amino acid in the cell. It will form diffuse opacities, okay? Diffuse stromal opacities, okay? So there will be the formation of diffuse stromal opacities. And we have the intermediate form of cystinosis. When the nephrogenic form is presented late in later life, it will be called intermediate form. So we have the nephrogenic, non-nephrogenic, and intermediate form. This condition is treated with a drug which is called cysteamine. Cysteamine, it is a substance. When we induce this, when we give this substance to a patient, it will go to the cells, okay? This will enter into the cells and will convert the cysteine into a different form of cysteine, okay? So we have, which is pronounced like the cysteine, T-I-N-E, okay? The cysteine will be converted into cysteine, like cysteine will be converted into cysteine, okay? So this cysteine is now, this is a modified form, which is now, it can be easily transported across the cell. So it can be treated by the cysteamine. Cysteamine can be given in topical form as well as systemic form. Okay. Now the third one is the Fabry disease. Okay. So the Fabry disease, it is an X-linked genetic disease in which there is the deficiency or absence of an enzyme called alpha galactosidase A. This enzyme is required for the metabolism of a glycolipid called ceramide trihexoside. So this enzyme is metabolizing this glycolipid. When there is the deficiency or absence, this glycolipid will accumulate in different types of tissues in the body. How the patient will present to us? The patient will present to us, the systemic features are, there will be multiple red spots on the skin, okay? There will be multiple red spots on the skin. These are called angiokeratomas. So the patient will present to us with angiokeratomas, and he will also complain of burning extremities, okay? So angiokeratoma, burning extremities, and there will be the renals and cardiac problems. Okay, so these are the systemic features of Fabry disease. Now when we take a look through the eye, there are some special type of opacities in the eye which are called vertex opacities. So in the cornea there will be opacities in a vertex form which is called vertex opacities. Okay, like in this vertex form. Okay, so these opacities are arranged in a special pattern due to the accumulation of the glycolipid. There will be the opacity in a special form, which this pattern is called vertex opacities. Okay, and in the lens we will have cataract. Like the Wilson disease, we will have which shape cataract. Okay, which shape cataract will be present in the lens. Okay, now the fourth metabolic disease is Mucopolysaccharidosis. Actually, it is a group of metabolic genetic diseases. How? For example, we know that it is the problem in the enzymes which are required for the breakdowning of long chain carbohydrates such as glycose aminoglycans. So we know that, for example, if this is one long chain carbohydrate, so there are multiple enzymes which are acting on this long chain carbohydrate and they are breaking this. Okay, so for example, if this is one enzyme, there can be two, this is 2, this is 3, 4, and so on. Okay, so when there is any problem with each enzyme, there will be a specific type of metabolic disease. Okay, so the problem can be in one enzyme, two enzyme, third enzyme, or in the fourth enzyme. So that's why it is a group of metabolic genetic disorders. Okay, but remember, there are many subtypes, but the common systemic features which are present, there will be the facial coarseness, and there will be the skeletal abnormalities and learning abnormalities. These are the common clinical features of mucopolysaccharidosis. And in the eye, there will be opacities. In the eye there will be dense opacities. Okay, and in between the dense opacity, we will have strong haze. Okay, so we will have dense opacities in the cornea. Okay, in the cornea we will have dense opacities. The systemic features I told you. So the opacities will be like, there will be dense opacities. In between these opacities there will be haze. Okay, so haze in between. Like I also discussed this type of pattern, but it is different. Okay, it is entirely different pathology. Like I have discussed this in the granular dystrophy. Macular dystrophy. Okay, so this was about the mucopolysaccharidosis. And we had the last of metabolic disorder, metabolic keratopathies. It is Lecithin-Cholesterol Acyltransferase deficiency. Okay, so it is also an autosomal recessive condition. What is the pathology? What is the problem in this disease? Is that we know that, for example, if this is a non-stratified cholesterol, this enzyme lecithin-cholesterol acyltransferase is converting this non-stratified cholesterol into stratified cholesterol. Okay, it will be converted by this enzyme, and ultimately this stratified cholesterol will be converted into high density lipoprotein called HDL. Okay, it will be converted into HDL. Now, in this metabolic disorder, there is the problem with this enzyme. It is deficient or entirely absent. So when there is the problem, when we knock out this enzyme, so stratified cholesterol will not be converted into its form, and hence what will happen? The non-stratified cholesterol, the phospholipids in the LDL, its level will surge up. They will increase in the body. Okay, when they are increasing in the body, what will happen? There will be the deposition of these lipids in the cornea. Okay, so there will be deposition of these lipids in the cornea. And remember, we have on this base we have two types of we have two forms of lecithin Lecithin-Cholesterol Acyltransferase deficiency. We have two types. When there is a total deficiency, okay, when there is the complete absence of this enzyme, so there will be the dense opacities, okay, there will be the entire cornea can be involved because of the intense deposition of the lipids, okay. But there is one form of this disease which is called fish eye disease, okay. Now the enzyme is not completely absent, it is present but it is deficient, okay. So it will cause a fish eye disease. In fish eye, we know that the fish eye is like, when we look through the fish eye, it is like there will be opacities in the periphery, okay, and in the center only a small area will be left, okay, a small area will be left. This is called fish eye, okay, only this small area will be left, and the opacities will cover the periphery. So this is called fish eye pattern. That's why when there is the partial deficiency of this enzyme, it will cause fish eye disease. Okay. So these were the metabolic keratopathies.